Little different change of venue here. Okay, so the world has become checkpoint-centric, and here's a perfect example of an autoimmune event. Man just lost his eyeballs. So this is where everybody thinks immunotherapy is or should be. This is not the way I grew up in immunotherapy. Immunotherapy to me for the last 35, 40 years really centered on the development of vaccines, trying to use the patient's own immune systems in very different ways with novel platforms. So keeping that in mind, just as a point of interest, this is an article that says vaccination against cancer may result from discovery by British medical experts. I will tell you that it comes from the Toronto Sun, but just looking at it, how many of you, and just raise your hands, think it comes from the 1970s? Any takers? 1980s? 2000? 2017? Anybody? Nobody thinks it came from any place, just came out de novo? All right, you're all tired. Well, look at the date. Toronto, the Globe, 1925. So we've been doing work with immunotherapy for a lot of years. It just didn't evolve as a plant that just sort of popped up. And despite that, it's taken even longer than the almost 90 plus years to really get a foothold in the area. Why are we interested in developing immune therapies for prostate cancer? I could be very positive and tell you it's probably the most immunogenic disease there ever was, but it's not. But we are very fortunate to have a wide variety of reasons where doing immune therapies would be very reasonable. And as you can see, among them, including a variety of different gangliosides, carbohydrate molecules that are easily expressed. They're either overexpressed or underglycolated as a normal cell becomes malignant, and that includes the 6 transmembrane epithelial antigen of the prostate, prostate stem cell antigen, PSA, prostate-specific membrane antigen, prostatic acid phosphatase, and the like. We're also very fortunate, and Harriet has given you a whole book, essentially, of the role of biomarkers these days, and we do. We have PSA. We can follow it very easily. We can also measure circulating tumor cells in patients with high-volume disease. But it's also widely applicable to multiple disease states, meaning you could use immunotherapy for somebody newly diagnosed, somebody who's biochemically relapsed post-primary therapies, or any line of ancillary treatment along the entire cancer continuum. And it has a very strong likelihood of being potentiated using a variety of different combinatorial approaches, including biologic agents. In fact, the NCI many, many years ago, probably in the 1970s, had its own branch called the Biologic Response Modifiers Program. And that was just focused on looking at the variety of different combinatorial approaches of trying autologous therapies that are derived from patients and putting it in combination with a variety of novel agents. But despite that, why have we failed? We have, to a certain degree. Well, there have been a wide range of cell-based vaccines, including GVAX, which was based on really significantly impressive preclinical studies that made use of prostate cancer cell lines, LNCAP and PC3, that were irradiated and ultimately co-incubated with patients' own cells and given back. And it was quite interesting because these animals had regressions. When combined with chemotherapy in a phase 3 trial, it didn't prove perfect. It was really did not do anything in terms of impact on the patients or overall survival. So we've gone through a variety of that type of approach. There have been vector vaccines, those with prime boost, where we take 2 different species of poxvirus in a prime boost type of approach to really stimulate the immune system and then come back with a unique platform of a particular immunogen. And then, of course, we had my own experience with the carbohydrates that, while very specific in generating an antibody response to the appropriate immunogen and perhaps a change in PSA slope, really did not translate into a biologic response. And if there's anything that you come away with in terms of looking at immune therapies, if, for example, you give a therapy and you're seeing antibodies, that's great. Maybe something is really revving up the immune signal. But if it doesn't translate into a biologic response, if you don't see a change in the behavior of the cancer, then it's really not going to be very helpful to what you are going to be doing. So there's been a lot of concern, Bob Schreiber in particular had been talked about immune editing, such that if the body is constantly searching and selecting for antigens that are foreign, that they want to cut out and get rid of. And it's interesting because it's actually based on a lot of the data that's been shown that if the body does edit and take out what is considered to be these immunogenic foreign proteins, that the overall molecule itself ultimately is going to have reduced immunogenicity, that the immune system is not going to see it, whereas if the immune system misses those little clips of peptides, that perhaps the immune system is just not what it should be, but that's how the cancer grows. So many of the therapies, as I'm sure many of you know, already are armed and dangerous in terms of looking at dendritic cells, whereby we have the antigen presented by the dendritic or scavenger cells, and it's made available to the immune system with the help of a vaccine. Similarly, one could use adoptive T cell therapy, chimeric antigen receptors, to really use activated T cells to get into that tumor microenvironment, because from what we've learned so far, it's very hard to get into the tumor microenvironment. There are multiple layers here, both of myeloid-derived suppressor cells. There's a variety of inhibitory natural killer cells. There's an extraordinary layering of cells that all they want to do is prevent the immune system or your product from getting in there and killing the cell. And of course, the checkpoint blockade, which is something unto itself. So I often have been quoted as being very negative about this, but the reality is we don't think of prostate cancer as an immunogenic cancer as we would of renal cell or melanoma, where there are spontaneous remissions and we know how the immune system seems to work. Nevertheless, there have been more and more papers that have come out that are showing within the tumor milieu that there are infiltrating T cells, helper T cells, and even those cells that are expressing interleukin-2 receptors. So there's clearly something that is going on, but whether or not it really helps contain the cancer itself and doesn't allow any sort of other immune populations to go in or drugs to go in remains to be determined. Let's put it this way, there's a lot of challenges that we're facing, and the problem is that while we've looked at autologous products, cells that are taken from the body and manipulated in some other way, the reality is that you need a product that is exportable. You need a product that is going to be reportable, meaning we need appropriate immunologic endpoints in order to really know if this worked. It's got to be translatable. I just mentioned you need a biologic effect to show that it's really worked, but we need a timetable. What's the anticipated time that it's going to work? We've learned from some of the checkpoint inhibitors that you might experience pseudo-progression, meaning that the cancer may look worse before it looks better, but the reality is that could take several months. And if you have people who are PSA neurotic, I can assure you they're not going to sit there and wait. They're going to want to change treatment strategy as soon as they see their PSAs double or triple. And again, we do not experience in prostate cancer what we have seen with melanoma and several other tumors of this idea of pseudo-progression in soft tissue as a response to immunologic therapies, largely because of the infiltration of immune effector cells. That's not been shown in some of what we've been doing so far. So Sipuleucel T, I think it's ironic that the first approved immune therapy for a solid tumor, and really the standard by which everything else is being followed, ends up not being a tumor that is so terribly responsive to the checkpoint inhibitors. One would think that this was sort of the segue into the generation of really a resurgence of immune therapies for solid tumors. You may recall that Sipuleucel T is an autologous product. Cells are taken from the patient, peripheral blood mononuclear cells. They're co-cultivated with a fusion protein that happens to be prostatic acid phosphatase and GM-CSF. And after 48 hours of co-incubation, it's returned to the patient as 3 separate infusions for a total of $93,000, of which 80% will be covered by Medicare. But it was the first to show an improvement of overall survival, but not time to progression. It is really the first as a personalized therapy. So you may recall that there is definitely improvement in the probability of overall survival, not by very much, but it was enough to convince the FDA. There was some suggestion, as you can see in the blue stippled, that overlaps with the solid blue line, that there may have been a survival benefit in those patients who had been pretreated with docetaxel. Fast forward to a much more perhaps scientifically based immune therapy was Prostate. Phil presented both of these in the past, but what was very interesting about Prostate is that this was a novel platform of the DNA transgene that was hooked up with 3 co-stimulatory molecules, ICAM, B7.1, and LGA, and it was given with a prime boost of either cowpox or foulpox virus, and in a sense to prepare the body immunologically for a following vaccine. What was very interesting is that there appeared to be a survival benefit, as you can see here, that was almost superimposable to what was seen with Sipuleucel T. Now, the data were convincing enough in the phase 2 to go on to the Prostate trial, which was a very large randomized multi-center phase 3 trial of approximately 1,300 patients. And this was actually conducted under a very special protocol assessment agreement with the FDA, i.e. that this would go on as a registration trial based on whatever the data. So the idea was to test whether Prostate, that was given either with or without GM-CSF, could prolong overall survival in either men who were minimally asymptomatic or asymptomatic metastatic castration-resistant prostate cancer versus placebo. And the data just came out within the last 3 weeks from the INDC, and based on a pre-planned analysis, and I can't tell you all the data because I don't know it, but continuation of the study was deemed futile. Now, this study really, I think, built the careers of many of the people at the NCI that worked very hard to bring this forward. Everybody was very disappointed, but this is just to give you the 3 arms. So based on preclinical work, as well as the phase 1 and the phase 2, the phase 3, which was wonderfully powered, had appropriate arms, did not prove to be clinically effective. But again, I don't have all the data for you, and it probably will not be out for quite a while. But in keeping with this, one of the other issues is that perhaps it's the wrong patient population. So we're actually doing part of another trial with Prostate in biochemically relapsed patients based on their PSA doubling time. So what have our lessons been in prostate cancer? I sort of say that the no's have it. And keep in mind, it's not what I would consider to be your typical immunologic solid tumor, or immunogenic, I should say. It is certainly not hypermutated to the extent of these other malignancies. We do know that if you give increasing doses of a variety of different kinds of vaccine platforms, it does not necessarily augment immunogenicity, but largely lower doses have actually been shown to be much more immunogenic. If you do generate antibodies and it does not have a biologic effect, that's not good. You want something that will translate into changing the biologic behavior. There do not appear to be potentiation of T-cell responses with standard vaccines, irrespective of the platform that's used. There's no evidence of pseudoprogression, and as we had talked about this morning, no abscopal effects, even in combination. And I would just point out to you that in this continuum of the mutational status whereby melanoma, non-small cell lung cancer, bladder cancer, renal cell cancer, and head and neck cancer are sort of tucked away on that side of the street, prostate's down in the next borough, so to speak, in terms of the mutational status. So breakthrough therapies, as we've seen in checkpoint inhibitors, really only help a minority of the patients. People come into clinic and they've seen the Opdivo commercial on TV, a better way to live, longer life, etc. But the reality is that the side effect profiles have not made it the easiest way of surviving. And for those of you who may have read USA Today, there was an article where a patient's survivor brother was interviewed in the setting of the patient having had non-small cell lung cancer and having gone on Opdivo. And the brother very poignantly said that he wanted his brother to have some form of quality of life But unfortunately, watching him undergo the side effects of a checkpoint inhibitor robbed him of that quality of life. And it is an extraordinarily poignant article. So you'll notice here in green that the response rate for the combination of PD-1 and CTLA-4, and this goes through the whole compendium of cancers on which it's been tested, or PD-1 or CTLA-4, really is a lot lower than the television or even the literature would tell you. This is just to remind you that we have those scavenger cells with the antigen-presenting cells or dendritic cells, which will pick up antigen. Antigen is anything that the cell finds or that it finds in the body, and that can include essentially products left over from cytotoxic chemotherapy, radiation therapy. And remember, cells go to the bathroom, as hard as it is to believe. They puncture their membranes, they're traumatized, and all of these waste products and the like are considered to be potential immunogens. They're picked up by the dendritic cells. They go into a little pocket called the major histocompatibility complex, which then engages the T cell receptor. In and of itself, that's not enough to happen. You need a variety of co-stimulatory molecules and have the go or not go. But there's one thing missing, CTLA-4, or cytotoxic T lymphocyte antigen 4, which is within the cytoplasm of the cell. This molecule can be upregulated and actually block this interaction and tell the cells, you will not engage, abort. It is also the main reason why we don't react to our own bodies, because CTLA-4 prevents autoimmunity. And in fact, preclinical models where you have the gene knocked down, mice develop myeloproliferative diseases and die. So it does play a role. So to that end, getting these checkpoint inhibitors have not been 5 minutes. I mean, look at the start date for CTLA-4 with the preclinical work, 1985, and probably early 90s for PD-1 and subsequently PD-L1. So these drugs took a very long time in testing before they even came out in the market. Our own experience in the phase 1, phase 2 with ipilimumab, with and without radiation, showed fairly profound responses in some but not all the patients. And in fact, for those patients who did develop autoimmune events, although it was not absolute, a lot of them had durable responses, if not cures. But it's the minority, not enough to prove perfect. Now, please notice here, a patient with a PSA of 100 underwent treatment with ipilimumab 10 milligrams per kilo, developed a transaminitis, a colitis, as well as a hypothyroidism, but had very, very significant response, as you will see. I mean, his PSA went down from 655 just about towards 0. And this is what this large prostatic mass invading into the bladder looked like 14 months later, and the patient remained that way even until current. The phase 3 of this, and again, this is all based on very solid preclinical and strong phase 1 data or suggestive data. And you can see here there really was absolutely no difference in patients with ipilimumab plus minus radiation versus placebo. So that led to, if it didn't work in the post-chemotherapy arena, maybe it would be better if we give it pre-chemo. So Tom Beer led the effort of a hypothesis that perhaps patients who would survive better if they had minimal disease. And that's basically it. Although in the further phase, the previous phase 3, there was a suggestion that patients who had visceral metastases likely did a lot worse. So this led to another phase 3 trial which showing a progression-free survival in intent to treat population, where statistically here and without prior therapy, made no difference whatsoever. So we have 2 phase 3 trials, post-chemo and pre-chemo, that did not show a survival benefit for ipilimumab. So ipilimumab, at least for what we're doing, is not a major effort. The PD-1s, the PD-L1 checkpoint inhibitors are appearing a lot better. And to that end, Julie Graf had presented this at several meetings, Julius University of Oregon, and really, I think Dana alluded to this, did a very rapid phase 1 to look for a signal. The signal being, could they find anything that might indicate an anti-tumor response in patients who had end-stage prostate cancer. And ironically, there were a lot of patients with visceral metastases. Unfortunately, not every tumor was biopsied, so we don't have that data. But in addition to profound declines in PSA, you'll also notice that adenopathy has really mitigated. Disease in liver has also become much, much smaller, and some of these have been durable. Again, just to point out, very profound declines in PSAs, but whether or not, and again, the presence or absence of microsatellite instability genes did not seem to make a major difference. I would point out that in spite of the fact of the agnostic approval of pembrolizumab for patients with microsatellite high in various tumors, that it is not a given that if you have microsatellite high and prostate cancer, you will respond. In fact, I can tell you of 3 cases where 1 out of the 3 actually responded. So that doesn't excite me to know that the person with the microsatellite high responded. My question would be, why didn't the other 2 respond? What made those 2 very unique? So speaking of unique approaches, you heard from Jonathan about our efforts with Vtp and focal therapy, which is really a rather interesting approach for local control, considering how the Vtp actually works and fosters an immunologic milieu within the tumor. We've also been working on CAR T cells that are directed against PSMA, a variety of different adjuvant and neoadjuvant approaches, as well as the use of immune modulators, as well as different platforms. I'm very, very briefly just going to touch on these. So one of the benefits of CAR, or chimeric antigen receptor T cells, is that you're actually taking the T cell receptor and you can actually change it in any way you like to express a particular epitope of an antibody. That against PSMA, that against a ganglioside, that against CD19, with the exquisite sensitivity that it will direct that T cell to that antigen that is expressed on the tumor cell. What's also very important here is that you don't need to worry about Hla restriction, which has always been an impediment. Our own experience had been with patients who had metastatic prostate cancer, and this was actually number 12 out of our 12 patients on the trial, where we decided in concert with Jason Lewis and Heiko Schoeder of nuclear medicine to determine if we could ex vivo label chimeric antigen receptor T cells that have come from a patient and reintroduce them after giving a conditioning regimen of cyclophosphamide, which knocks down regulatory T cells. So this is the contrast-enhanced CT, and this particular person happened to have very prominent adenopathy in the hilum, in the particular area you can see right here. And when we, after we then we did an FDG PET scan, as you can see here, it lit up. We actually biopsied this. It was chock full of PSMA expressing cells. None of the cells expressed PD-1 or PD-L1. However, after giving a T cell infusion, this is just a CAT scan again to show you, but 6 days later, you still saw this area light up. So does that mean that this is one of the best ways of getting T cells in? It shows us there's activity. We subsequently have biopsied it and have not seen any major inflammatory activities, but the kinetics of this patient's PSAs have definitely changed, and his scans have been stable, particularly in those areas of the adenopathy. There's no question that enzalutamide is an immune modulator. Now, immune modulation, as I know it, is to really talk about the ability to change the phenotype of that tumor cell. Not the genotype, but the phenotype. Can we change the superficial antigens that are already there? And based on some very elegant preclinical study by Dr. Dodge's group at the NCI, he looked at enzalutamide and did several experiments in preclinical TRAMP models alone and with using enzalutamide alone or in concert with a vaccine. And what I would like you to take away with here, of course if you could see it, is that the effects of enzalutamide is that, number one, it caused the genitourinary tissues to become smaller, i.e. the prostate, but it did enlarge the thymus, which was very interesting. They also found that there was an increase in what they call Tregs. So this is T cell receptor excision circles. And what these are extra chromosomal DNA byproducts of T cell receptor rearrangements, and these are usually expressed in cells that are of thymic origin. Now, what makes this very interesting is that while under the influence of enzalutamide, we didn't see increases in T cells or B cells or anything like that in the thymus. What was very interesting is that it can, in and of itself, does not stimulate an immune response, but it did cause immunomodulation, meaning that it could actually be used to influence a combination with another drug. And that's exactly what it did in combination with a vaccine that was used in these mice. This is just to remind me that there are still people who are working on vaccines. The world, as I said, is not necessarily checkpoint-centric. Here's a study of a group of patients who had biochemical relapses, received a vaccine after getting docetaxel. The vaccine happened to be autologous dendritic cells that were co-cultivated with LNCAP and then returned to the patient. What you can see here is that pre versus post-treatment, that there was definitely a change in the PSA doubling time. These patients' scans have remained absolutely stable, and not only did they do one course of immunization, but several courses of immunization, and were able to maintain stable PSAs for well over 2 years. So this is based really on a phase 1 showing safety and efficacy. And this is a heat map just to show that T cells were in fact activated, that there was some level of inflammatory and angiogenic side effects, but nothing else in terms of major apoptosis. But there did appear to be some increase in T cell cytotoxicity. So, closing remarks. How to position immune therapy in castration-resistant prostate cancer. Well, I've already told you you can use immune therapy at any time along the disease continuum, but we do need to have defined endpoints or biomarkers that will correspond to a biologic effect. CTCs and the elegant work that Howard and his group have been doing is one approach, but there has to be something from an immune standpoint that we can use to really tell us what's going on. PSA alone is not a reliable indicator because we have patients where we're treating them beyond progression, and the fact that their PSAs are going up, but their scans may be absolutely stable. And there is a tremendous amount of data that's out now suggesting that you can use combinatorial approaches, perhaps radium to change the internal milieu, use enzalutamide, because you already heard that enzalutamide in some patients that were treated first, followed by the pembrolizumab, actually seemed to have a better response. So there's something that's immune modulatory. We know that overall survival continues to be an endpoint in these cases. However, one has to go back and take a look and see whether or not it really depends on the clinical state. Is really overall survival appropriate for every clinical state that we're talking about? So the most important is, what about the checkpoint inhibitors? There's still several of them, ICOS, VISTA, there's myeloid-derived suppressor cells. Could they possibly be used as biomarkers? And again, there's a lot of preclinical data looking at it. Keep in mind that when we're looking at these markers, there is still a variety of different reagents that are being used. More recently, thankfully, there is a new test, the SP2 test, that will validate the presence or absence of PD-1, but that's not the usual case. We've already heard that there are basal and luminal differences, so that may play a role. But in reality, the immunologic platforms that are out there really vary. So just in closing, we really don't have standards in terms of how do we really deal with the checkpoint inhibitors in prostate cancer? How do we really assess response other than that which is seen on a scan? And it may very well be that checkpoints are very specific for very specific cancers, for prostate seeming to be the exception. There's no question that there's a lot of compelling evidence that there's a lot of tumor heterogeneity that may be influenced at the genetic and epigenetic level. And more importantly, there are now probably more than you can imagine in the literature, multiplex biomarker panels that are being encouraged. I mean, there's a whole systems analysis that's ongoing in the literature of developing these biomarker algorithms of how does one know whether or not a biomarker is relevant and how to design the trials around it. So with that, I'm going to thank you for your time and your attention.